Hi guys, just bear with me whilst I try and share my screen. I'm not fantastic at this Zoom thing yet. Okay, can you see that, Lucy? Can you just give me a nod?
Yeah.
Perfect, thank you. So thank you very much for having me today. Oh, give me 2 seconds, I'll pop up. Okay, so yeah, my name's Holly, and I am your medical student you're meeting today. Firstly, I'd like to say I'm sorry if my voice goes at some point. I've actually been really poorly with tonsillitis this week. So if I have to reach for my tea or have a sip of water or anything, then I do apologise. Sorry, my Zoom's being really funny. Just bear with me 2 seconds. This is why. There we go. Okay. So if you want to keep cameras on, that's absolutely fine. If you want to keep cameras off, that's absolutely fine too. Like Lucy said, if anyone has any questions, anyone wants anything clarifying, then please unmute if you feel confident enough. I don't mind being interrupted in the slightest. In fact, I'd rather be interrupted and to clarify things at the time. We will have a Q&A at the end as well, so if you think your question can wait to the end, then that's absolutely fine too. And yeah, I think we'll just crack on because I've got quite a lot to cover. Probably a question to answer before I go through what I will cover is why we're here. So to my knowledge, you guys are all prospective medical students, hopefully. You're all maybe looking or considering applying, maybe you have applied, maybe you've got some interviews lined up. So no matter what stage you're at, it's a really good idea to get a bit more of an idea as to what sort of being a medical student involves. Hopefully it's interesting. Hopefully it will inform your decision as to whether this is the career for you. Hopefully it is, because it's a fab career. But kind of on the more mundane side of things, if you do get an interview, if you do submit a personal statement, you're going to have to be able to show what you think being a medical student's like, and that you know what the challenges are, and kind of the reasons that you're going into it, and you've got a realistic insight into what you're letting yourself in for. Because this could be the next 6, 7, 8 years of your life, depending on how old you guys are. So it's important that you're making the right decision. So what I'm going to cover is, oh, no, not let me go through, there we go. So my journey so far, so what's led me to being where I am. Why do medicine? It's like the age-old question, isn't it? Why do medicine? Work experience and volunteering I'm going to touch on, and it will be a touch just because I know that Medics&Me do quite a lot of this stuff outside of this talk as well. A day in the life at medical school. I think this is the kind of bread and butter of the talk, in that it's hopefully going to give you kind of the ability to visualize what being at medical school will be like. Why emergency medicine is the best ever. So I need to plug what I'm interested in, I'm afraid. So I'm interested in, emergency medicine. So I'll go through a little bit of that. The challenges of med school, of which there are many. And I wouldn't be doing my duty or my job properly if I didn't talk about them, and we need to talk about them, because we need to find some solutions, and also you guys need to be informed because it's a challenging career. The thing that I will say is that the challenges are 100% worth it for me. I listened to one of the consultants' talks actually that Medics&Me have recorded, and I think he said something like, there will be tears and you have been warned, and there will be tears, but you're going to have tears in life as well. So it's not a reason to avoid the career. You'll get a lot of people slating it maybe, and I think we need to deal with that in a kind of constructive way. So we'll go through some of that, and then we'll have a Q&A at the end. So briefly, a little bit about me. I'm a final year medical student, which means that in July, I'll be practicing as a doctor. I've studied for 6 years at the University of Manchester. I'll go through that a little bit more in a bit. It's a 5-year course. So why have I been here for 6 years? I've basically done another degree, but I'll talk about that later on. I'm 23 years old, so I've gone straight into medical school from school, which means that I am due a gap year, and I'm really looking forward to my gap year when it comes along. Like I said, I've got an interest in emergency medicine, pre-hospital medicine, which means any medicine delivered to a patient before they get to hospital. So helicopters and road access doctors, things like that, so where we take the hospital to the patient. Medical outreach, so delivering medical care to people who don't necessarily have access to it, and travel. could be persuaded to join the army. That's probably a new one. I think my brother's on this call, and he might be raising his eyebrows at this one because I'm not sure if I've talked about it. I think I do want to join the army at some point. And that's a decision to be made later down the line, probably in 3 or 4 years' time. And I really enjoy my life outside of medicine, and that's a big take home from this talk. Is it's really important to have a life outside of medicine and to make sure that other things essentially give you pleasure other than medicine. So traveling, that's a big theme. Cooking, netball, play a lot of netball, have played a lot of netball my entire life. The pub, I'm here to keep things realistic, guys, as well. I'm not going to lie to you. Seeing my family, and yeah, love a good coffee as well. And I'm a southerner up north. So I'm from, I don't know if you can tell, probably can, I'm not from the north. I'm from the bottom red circle, which is a place that's on the Dorset-Devon border. And it looks a little bit like this. So it's fair to say I was born in the countryside, very much raised in the countryside on the coast in a beautiful area. About 45 minutes away from the nearest hospital. We're in between 2 hospitals, and probably a similar distance from the nearest city. And then I moved to probably one of the biggest cities that there is in the UK. It's hectic, it's big, it's scary. And medical schools tend to be in big cities. That's a big theme. Universities tend to be in big cities. So yeah, it's been a big journey. So my journey so far, 2 questions I get asked a lot by prospective medical students, by my mentees, people like that, are when did you want to become a doctor and how did you know you wanted to become a doctor? And I'm afraid I've got a really unsatisfactory answer for this. It's not the same for everyone. Some people it builds on gradually, some people, everyone has different factors that lead them into this career. Personally, I don't have anyone medical in my family, so it wasn't a family member that kind of prompted me into wanting to become a doctor. And the answer is, and this is the honest truth, I wonder if you guys are old enough or young enough, old enough to know where these are from. So top left is Holby City and bottom right is Casualty, which is a tragic and terrible way to want to go into medicine. It's like wanting to be a lawyer having watched Suits. Really unrealistic portrayal of medicine, disclaimer. Not the only reason I wanted to go into medicine, but definitely a big part of it. So me and Mum would sit down on a Tuesday evening at 8 o'clock and watch the episode of Holby City when I was about, I don't know, probably started when I was like 8 and went up until I was about 16. So it's a long time. This is my mum. So she's a physiotherapist. She's probably hating the fact that that picture's up there. She works from home and she has a clinic room actually in our front room. And I think actually that had a bit more of an impact than I realised growing up. There was always that kind of clinical aspect to work and things like that. And it was something that I was quite drawn to. And just to give you guys a bit of insight, this is my medical practice, which is like a house. Really sort of countryside medical delivery. And it was run by 2 GPs, her husband and wife, for decades, essentially, who were the village's doctors. And so everyone had quite a high esteem of them. And I think that may have rubbed off a little bit. Yeah, there's lots of different factors that brought me into medicine, essentially. Holby City and Casualty being a disappointingly large amount. But it's great because I love it. So why do medicine other than Holby City? So this was my textbook kind of, what should I say, interview answer. And I sort of harped on and I sort of said, oh, it's the perfect blend of science and human interaction. But I really stand by that. I don't think you can name another job where you use your brain as much as you do, you use human biology as much as you do, and you have such an impact on human beings. And medicine is 75-80% human interaction. It just is. Especially at junior levels, especially as med students, you have so much interaction with human beings, which is fantastic. And it's definitely one of the draws to medicine for me. But I also really liked science. I loved biology, and there's just a perfect kind of combination of both of them. So I stand by my 17-year-old self, and I took that phrase to interview. You can take that down if you want. Medicine's privilege, and this is becoming more and more apparent, I guess, the closer I get to qualifying. Especially having spent a year in A&E, medicine is a chance that humans give you when they are at their most vulnerable to have a massive impact on their life. And they lower down their walls that they show to probably 99% of the sort of strangers, and you are given this rare, amazing insight into their world and their life. And to have that, the ability to have that sort of impact and view into someone else's life is a huge privilege. And to then be handed the power to make a big difference in that human's life is a huge privilege. And it's got to be one of the most privileged jobs out there. There's no other job, I don't think, where you get that same level of trust placed upon you, and you get the opportunity to do as much good, is the way I describe it. It's exciting. You get to see loads of things. Med school's exciting. You get introduced to like weird and wonderful stuff that you haven't even realised existed. It's continually evolving. So that's dead true, and that will carry on being true. One area of medicine that is mega at the moment is the use of AI in diagnosing and imaging, in treating. Obviously the cancer side of things is continually evolving. There's lots of money going into that. Research is happening every single day without us realizing it. Papers being published every single day, and to be a part of a career that is evolving as rapidly as medicine is exciting. It's dynamic. Varied career directions. So the way I describe medicine is you have 5 or 6 years at med school that everyone has to do. You've got the next 2 years as a doctor, so F1 and F2, after you graduate, that everyone has to do. And then there's hundreds of doors after F2. Like, you've literally, after those first 7 years, you've ticked every box and you can just run with it. And where you run with it will depend on what you prioritize in life, what you want in life, what balance you want, what your interests are, how much of a combination of, you know, human interaction versus research versus whatever. But there are hundreds of doors. It's not one of those careers where you start, you're pulled up, and then they try and make you into a sort of a perfect, I don't know, person, colleague, excuse me. There's not just one trajectory, there are hundreds, which is really exciting, because you can make it work for you. Lots of emphasis on teamwork. It's a very social job, and you get to meet some fantastic people, not just other doctors, but HCAs, nurses, cleaners, porters, you know, occupational therapists, physiotherapists, like, you name it. It's fab. It's rewarding sometimes. Sometimes the gratitude doesn't quite reach you. Sometimes your hard work goes acknowledged and unacknowledged. But it is rewarding, and you do get to quite often reap that reward. And there's an opportunity to travel. So travel's a key theme in this, isn't it? I hadn't quite realised how much I've mentioned it, but and there's travel again. Ability to pursue other opportunities. So if you like teaching, you can teach. If you like giving talks like this, you can give talks like this. If you want to lead teams, you can do that. If you, I don't know, if you're into climbing, like, go and do some wilderness medicine. You can really embrace your areas of interest and kind of incorporate it into the career. There we go. And sometimes you need that, because you get things like this where you see the less glamorous side of the job and you need to remind yourself why you're doing it. But yeah, there are lots of good reasons. So very quickly, I went to a grammar school, which is non-fee paying, which is important to mention because obviously med students come from various different backgrounds, but it's good for you guys to get an idea into the facilities that I was given when I was a student, essentially, when I was a secondary school student. So for A-levels, biology, chemistry, history, drama. History and drama were without doubt my favourite A-levels. Biology and chemistry I could take or leave. Plant biology wasn't interested in, human biology more so. Played a lot of netball, as I've mentioned. Did the DAV award. Paid work, I did a lot of paid work, and that's something again I want to emphasise, that you can do paid work when you're in sixth form. Not every ounce and shred of your attention needs to go onto schoolwork or your medicine application, and actually you'll find you're better off doing some paid work, or doing not even paid work, just having other interests. Friends, I spent a lot of time with my friends. I was quite social, yeah, 12, 13, and then I put both because I also had and still have an obsession with Friends, the TV show as well, so I watched a lot of telly. Glandular fever and tonsillitis, a lot. That's relevant, isn't it? I was that kid when I was your ages, so when I was between 16 and 18, where I would have tonsillitis every like other month. I was constantly on antibiotics, was constantly missing days of school, and then I eventually got glandular fever, which is a longer term, more of a chronic tiredness illness. And the reason that I put that in there is because like life gives you lemons sometimes, and you just got to roll with it. And I think a lot of students think that one sort of big issue that's thrown at them will have a horrendous impact on their application to medicine and will mean they can never be a doctor. That's not true. I was lucky in that I got the grades. If I didn't get the grades, I could have retaken. You know, I could have had mitigating circumstances. There are things that you can do to get around the problems that life throws at you. And they do throw problems, you know, it does throw problems when you're in sixth form. But don't think it's the end of the world, is my point. You can work around it. Okay, so work experience. I'll go through my top tips in a second. I just wanted to give a sort of insight into the work experience that I had as a student and how that helped my application. So Bridport Hospital was the first place that I got a work experience placement, and I appreciate that it's really difficult to get work experience at the moment. I appreciate that COVID's had a massive impact on that. I appreciate that you're probably looking at the word hospital and thinking, how the hell did she get into that? Hospital's a really generous word for this place. It has one ward. It has like maybe 2 doctors present. It has a bit of a minor injuries, and it's not really a hospital. I think I've got a photo of it. There you go. It's tiny. It's more of a like, well, community, yeah. It's one of those hospitals that have basically been shrunk down because of funding, and will probably be closed soon. And in this work experience, I was never with a doctor. So I spent the day with nurses. I spent 2 days in the kitchens, and I spent a day, I think, or a day and a half in reception. And at the time, I was a bit put out, and I sort of thought, well, this isn't really work experience. It's not with a doctor. But actually, you look back and the way that I used it, it was really, really beneficial. So I spent time with nurses, which gave me an insight into nursing and how doctors and nurses work together. Spent time in the kitchen, where actually like the amount of food hygiene that goes on down there for sick patients is insane. I learned how to make a very sterile sandwich, and I linked that back to medicine by talking about infectious diseases, about the importance of hand hygiene, about the importance of feeding patients when they're in hospital and feeding them healthy food and nourishing food, which is far more holistic than spending the day on a ward round with a doctor, I would argue. Days in reception, half of medicine is admin anyway, but I learned how to talk to patients. I learned how much paperwork there is in running, I'm going to say hospital, running a medical area. I learned how to deal with conflicting situations, with confronting situations where patients weren't happy, confidentiality, patient notes. So my point is, guys, like find the links between what you've done and medicine. There are always links. Like if I can link a kitchen to medicine, then you guys can find links and things. I was lucky, so my local hospital, which is Exeter, ran a taster week for prospective medical students. And I did that. It was mainly talks, a bit like this actually, from consultants, from registrars, about kind of different career aspects of medicine. And then I'll put my hands up and say I had a very good contact that got me into a hospital in London. The one caveat to that is, yes, I mentioned it in my personal statement. No, I did not talk about it at all in my interviews. And I do not think that that week got me into medicine in the slightest. I think that the way that I used Bridport, Exeter, and then my paid work and my voluntary work was far, far better than saying I spent a week in the Royal Free in London shadowing some doctors. Brownie guides. So as part of my DOV, I helped run brownie guides, which is fun. And where's the link there? Well, the link is, okay, I'm able to run sessions for kids. I'm able to work with kids. I'm able to deal with bullying situations. I'm able to deal with, kids with, rubbish mental health. I'm able to be engaging and be a leader and work on teamwork. There are so many different areas of medicine that you can unpick in terms of your experiences. Paid work. So I worked in a fish and chip shop for about 7 years. I've literally, like maybe 3 years ago, finished working there. And I believe that's what got me into Manchester, because I had a station, an MMI station, where I was asked to talk about a certain area of my personal statement that included that fish and chip shop job. And I spoke for about 8 minutes just about how working in that environment makes me fit to be a doctor. It's a stressful environment, it's a high pressure environment, it's an environment where like you rely on teamwork. You know, if your mate around the corner doing the pizzas isn't on the pizzas, then you can't wrap the chips to get the order out to number 71. It's an environment where there was a lot of conflict. Like some people, tourists aren't very friendly sometimes. It's an environment where perhaps my management, so my boss wasn't fantastic, so I had to navigate that. Had to, like, there's so many different areas that actually that really shaped me as a person. And I spoke about that for 8 minutes, and I think that may have sealed the deal. I also chambermaided in a hotel and I waitressed as well. So onto my application process, I did the UKCAT, now it's called the UCAT, I think, for you guys. I didn't bother with the BMAT, so I'm not too good at giving advice on that. Had my personal statement handed in by October. My school proofread it, but didn't really add much, and I didn't get too much support with that. So you can get adults to proofread your stuff, that's fantastic. Received interviews from Manchester, Birmingham and Cardiff. My other one was Bristol, didn't get an offer, didn't get an interview, got rejected at the first stage. All were multiple mini interviews. They all felt a very long way away from home, I have to say. I read up on the current affairs at the time, so junior doctor strikes, and we have done a 360 there because that's also going to be an issue for you guys to read up on as well. You've got some strikes coming up. Ebola virus and Zika virus were a thing as well. Ethical pillars of medicine, I'm going to touch on that in a second in my interview slide. And I knew my personal statement inside out, back to front. I got offers for all three. I was very lucky and I was very privileged. And I couldn't decide. And my dad, I think is also on this talk, who's a Scouser from Liverpool, who has been brought up to hate Manchester, especially Manchester City and Manchester United. I think Manchester United more because he's a Liverpool fan. I said I want to go to an open day and he said, oh, you don't want to go there. And I said, no, I think I do want to go an open day to Manchester. Anyway, we went grudgingly, and it was a beautiful sunny day and I pretty much fell in love with it. And I thought, no, this is it. So the interview, top tips. What would you like to see if you were an interviewer? Come up with a list of maybe 10 qualities and see if you can reflect that in yourself. Be prepared to talk about anything and everything. So you can practice this. Any family member, any friend, any teacher, whatever, pick up a magazine, a newspaper article, read it, and then get them to quiz you on it or get them to talk to you about it and see how good you are at ad-libbing and talking about things coherently that you've read up on, essentially. Get used to debating. I had a few debate stations. I had the classic was who receives the liver transplant. Is it the 56-year-old alcoholic? Is it the 21-year-old who's got 3 kids and an autoimmune condition? Is it, I don't know, and you had to kind of just go through, and the answer is there's no right answer. You just had to show sort of equal measure and weigh up pros and cons. If they're rude, don't worry. I had a station in Birmingham where the lady didn't look at me in the face the whole time, like stared at the bottom of the room, and there was nothing more like disconcerting than when someone doesn't like engage with you properly. But she was told to do that. I was told at the end of the interview, and she was told to be rude to you and see how you reacted to it. Get used to talking about yourself. Know your personal statement, definitely, and your work experience. So whether it's volunteering, whether it's work experience, whether it's whatever it is, like find those links to medicine and use them and say, this is why I'm suited to being a doctor. Know the ethical pillars of medicine and get to used to using them in conversations. So there are 4 medical ethical pillars in medicine. So you've got non-maleficence, beneficence, autonomy and justice. I think I've got a photo of it coming up. If I'm talking gobbledygook, Google them and use them when you are weighing up ethical decision making, essentially, in medicine. Be prepared to talk to a patient. So they will get actors in and act as patients. Again, you're not expecting to know anything. It's just how you interact. NVQ stands for non-verbal cues, and they are really important. So posture, what you're wearing, eye contact, where you're looking in the room. Too much eye contact, weird. Too little eye contact, not fantastic. So get used to conversing well, and non-verbal cues count for a ridiculous amount of how you come across to someone. rather than what comes out here. Be early, plus, be early, just be early. There's nothing more stressful and more distracting than not being early. And just practice, essentially. And this is a tip actually that my mum taught me, which is any exam situation, whether it be a written exam, whether it be an OSCE, whether it be an interview like this, if you tell yourself, I'm here and I'm going to have fun with it, like I am going to have fun, I will enjoy this process, no matter whether you believe it or not, you will actually perform better. And I've tried it and actually I think it works. So if you need to stop, you need to physically tell yourself, like, I am going to enjoy this, I'm going to use this and I'm going to enjoy it. Just give it a try. This is sunny Manchester. It's not sunny all the time, and it's kind of a gross looking medical school, but it's fab. So Manchester Medical School. First and second year are preclinical, which means that you are not in hospital yet. These are taken up by lectures, they're taken up by anatomy room, dissection room, seminars, small group seminars, communication skills sessions. So basically you are based on campus at your medical school. Third year is your first clinical year, which is essentially like, it's a bit like an apprenticeship without being paid. So you're on the wards, you're in hospital. Most of your time now is spent in hospital. You feel a little bit more adult, you're getting up at like slightly earlier. It's a little bit grimmer, but like, it's really cool because you actually see why you're there and you get to sort of use the stethoscope rather than just listen about it, and speak to patients and do cool things, which I'll talk about in a second. You have an opportunity to intercalate after third year, and intercalating is what I was talking about before. So it's the opportunity to step out of your 5-year or your 6-year, probably 5-year degree, and study something else for a year, usually medically related, and it's essentially a specialised degree that's been condensed down into a year. You can run away with a Bachelor's of Science or Master's of Science or a Master's of Research, so really good degrees. It no longer counts for your application for F1 and F2. It used to count quite a lot. It no longer does, but it will always benefit you later on down the line when you're going on to specialty training programs. Always good to have another degree. Not essential by any means. The reason I intercalated was to give myself some more time as a student, because I felt a little bit panicked about, graduating and responsibility. I was able to live like sort of a normal student, normal inverted commas, for a year. So I had lots of time off. I could fill it with other things. I had a job. It was a really good year. That being said, absolutely not necessary at all. 4th year and then 5th year. So you have 2 opportunities in Manchester to intercalate between 3rd and 4th, or between 4th and 5th. I think there is also an opportunity between 2nd and 3rd, but not many people take that at all because a lot of people are sort of desperate to get into hospitals. So a day in the life of a preclinical medical student. This is the stuff that's quite interesting now and good for you guys to know. So not that bit, that's not good, that's not interesting. So wake up and had breakfast, very important. I then took the bus up Oxford Road and attended a PBL case open session. So I will go through what PBL is in a second. It's quite important to get to grips with what PBL is, which is the format of teaching that Manchester Medical School use and a lot of other medical schools use. At around 11 o'clock, you might have an anatomy session in the dissection room, or you might have a communication skills session where they get some actors in, or you practice your examination skills, or you practice talking to patients. Manchester are quite hot on that. Have some lunch. And then you might have some lectures in the afternoon, which is done in sort of big lecture theatres, 300-400 students. COVID, I don't know how that's impacted on it, I won't lie. But my understanding is that universities are trying to get back to as much as normal as possible. Bus home, dinner. I played a lot of netball, so I'd probably have some netball training. Bed, or like I said, guys, I'm being real, maybe a night out, or maybe bed. So what's PBL? PBL stands for problem-based learning, and it's something, like I said, that Manchester do, a lot of other unis do. Some unis do CBL, which is case-based learning, which is similar-ish. So just read up, if you're applying to a medical school, know what format of learning, of teaching they give you. So problem-based learning is essentially where you work in small seminar groups, a bit like this one. So you'd have about 10 in your group, and you are presented with a patient case each week. And I'll give you some examples of that in a second. So we had case open on a Monday, case close on a Friday. So these are the cases, and this is the example that Manchester gave for semester 2, so from January to July. The semester has a theme, and this theme is cardiorespiratory. So you look at the heart, you look at the lungs, and you look at the circulatory system. And all of these cases relate back to lungs, heart, circulatory system. So for example, Stephen Thomas was someone who got stabbed into the chest cavity. So he had a penetrating trauma. Leukotriene was someone who had asthma, and that actually, if you are a medic, that's a bit of a play on words, because leukotriene is actually an inhaler that you give asthmatics. No, it's not, it's a pill. It's a medication that you give asthmatics. Albert was a heavy smoker and had a persistent cough. Wasim Ahmed was someone who went into heart failure. Catherine Poole had maybe also heart failure, had hypertension, so high blood pressure here, blood pressure problems. Clive Lott, which is also a wordplay, so clever you if you spotted it, because it's C. Lott, which is clot, had a MI, so myocardial infarction, which is a heart attack, which is a clot in the heart, where the heart doesn't get enough blood. And then Bethan obviously was in some sort of horrible trauma and probably had some sort of trauma to her chest cavity that would impact on her heart and lung function. So I hope that's given a bit of an insight as to how the cases relate back to the overall kind of theme of the semester. It's very cleverly done, actually. I've used a different case here. So this was actually me 5 years ago. This is a proper photo of what we did in my PBL session. So Tracy's a lady who gave birth, and she had a sort of like, her case was about pregnancy. So we went from her trying to conceive to her being pregnant, the 3 trimesters, and then her giving birth. So it wasn't a medical case in that she got sick, but she was obviously giving birth and was in a medical situation. So we took cues from pregnancy, and oh, I think someone's unmuted there. We took cues from Tracy's pregnancy, and we were basically like, okay, so she took a home pregnancy test. How on earth does that work? She took folic acid throughout her pregnancy. How does that work? Why is she taking that? Does everyone have to take the same amount of that? What does it do? She had some ultrasounds during her pregnancy. So she had a 12-week and a 20-week scan. What do they look for? What abnormalities can they pick up? What screening's available for pregnant women? So essentially we'd come up with a bit of a mind map like this. We adopted a biopsychosocial approach. That's in a star, guys, because actually if you mention that in your interview, then you'll be absolutely smashing it. Bio stands for biology. So things like, how does a baby actually form in someone? What are the different kind of processes of labor, of pregnancy, of newborn development, things like that. So the kind of real nitty gritty medical stuff. Psych stands for psychology. So how does having a baby impact on your mental health? How does, like, what's antenatal care is available to Tracy? Women who can't conceive, women who are trying to conceive, women who go through miscarriages, the impact that has on family members, things like that. So it's a lot more kind of the psychological, emotional stuff. And then social is things like, what care support plans are available for women? What are the actual rules of maternity leave or paternity leave? What funding is available for a pregnant woman or a woman who's just given birth? What grants? Stuff that actually we should really know, but we don't want to get sidetracked just down the biology route. So it's quite a holistic, which means all-rounded way of approaching a case. And then we come up with this, which is a learning agenda. So we come up with lots of questions that we want to answer. So what I've just been through. So you know, what is ultrasound? How does it work, etc. And we would all take a list of that home, and then we would come back with the answers in our case closed session, which is on a Friday, and we'd discuss it in a group. So we'd bounce off each other, we'd answer some, someone else would answer some, and it was a really good way of learning, essentially. Come up with notes like this. I found the pictures of these the other day, and I was like, and I felt a little bit like this. And some of you might be looking at that thinking, how do you possibly cover every area of the human body and retain all of those information? And that's the beauty of PBL, because it follows a cycle. So you learn some information and you then apply that information in your clinical years. So there's only so much book learning that you can get done in first and second year, and there's only so much that you can retain for exams, etc. And then you get into third year and you think, actually, or fourth year, I'm on Nobs and Gynae ward, I'm watching women give birth. What can I remember? And I've learned it once before, I can relearn it again, but probably slightly quicker this time, and I can also apply it. So that's the beauty of problem-based learning, is that it's a bit of a spiral and it's constantly going. And whenever you're on clinical years, you will constantly be reminded of what you should be learning, what you learned, sorry, in first and second So I thought that was quite a good way of sort of explaining it, that photo. This is more embarrassing for me than I've probably realised, but this is really important, guys. You can have fun as well. It's not all learning. It's not all like sort of studying at a desk and having no social life. I think I worked out, I sort of went to like 12 or 13 different fancy dress things just in my first semester, so out to Christmas. Did some wholesome things as well, played netball, had family up and visiting, had a formal that you can see in the top left. So there's definitely fun and games to be had at uni, and you can definitely act as a normal student. You just might have slightly more on your plate as a medical student. So moving on to clinical years. So we're year 3, 4 and 5 now. Wake up slightly earlier, coffee in the car. You kind of feel like you're a member of the working world at this point and not as much of a student. If you're on surgery or if you're on A&E, you will start at 8, which is flipping early. If you are on a medical round, if you're in GP, some GPs you start at 9. And then you spend your day basically less structured, and you, like I say, you're filling in as an apprentice role, so you're learning how to do the job on the job. So you'll have different teaching sessions, you will be shadowing doctors and nurses quite a lot, you'll be sitting in clinics, taking histories, speaking to patients, helping with jobs on the ward, practicing examining patients, applying your knowledge that you've basically got in first and second year to real life situations, getting used to being in that clinical environment, using those stethoscopes. And you'll also have teaching sessions. So these are intermixed with clinical days, and involve a big mix of skills. And I'm going to go through some of those skills because I think it's exciting for you guys to know what you could be trained up on, and what you could learn at medical school. So I was going to do a name skill, but actually in the interest of time, I'm going to kind of go through them, I think. So starting easy, that's obviously being able to take some blood. Sorry if anyone's squeamish, by the way, that's a bit of a trigger warning. That's a cannula, so these are the kind of bread and butter things of med school. So there's no needle in there, there's just a plastic tube, so you use a needle to introduce a tube into someone's vein, withdraw the needle, and then we can give some IV fluids. This is an ECG, which stands for electrocardiogram, and it's electrical recording of the heart. Get to look in ears. Not all patients are as cute as that, let me tell you. Like if you get an 80-year-old Derek full of wax, it's not that cute. Look in people's eyes. This is a catheter. So essentially where you introduce a tube into someone's urethra and into their bladder to allow them, for various different reasons, to be able to not have to get up to go to the toilet. And this is suturing, so wound closure. If anyone's surgically inclined, there's quite a lot of opportunity to get hands-on experience with that. And the biggest one of all probably is communication skills. So like I say, about 75–80% of medicine is being able to talk to a patient and being able to communicate things when they're in that very vulnerable state and you are having that impact on them. And it is a skill that's very undervalued, I think, in medicine at the moment. And it's really important. Yeah, I think managed to do a good job on focusing on communication skills, but it's something that is part and parcel of the job. This is a chest x-ray, and actually maybe the more medically minded among you may be able to notice what's wrong with it. So you're supposed to compare like for like, so have a look at symmetry. They obviously do not look symmetrical. This looks a lot bigger. You can see lovely lung markings reaching the edge here, so we want lungs to fill this sort of thoracic space, and unfortunately we do not have that on this side, so we've got a lot of air. And what happens is that air will keep building, and it's already happened in this patient where the pressure has caused stuff that should be lying here to move into their left-hand side. So this is your heart, should really be sat here. Their windpipe, their trachea should really be central. And this is a very, very sick patient. And if nothing gets done, they're probably going to die. So that's chest x-ray. That's an ECG. This is also a really scary looking ECG. That shouldn't be there. This patient is having an acute sort of heart attack, essentially, and which is different from a cardiac arrest. So cardiac arrest is where your heart stops and you pump it. Heart attack is where your heart isn't getting enough oxygen and may lead to a cardiac arrest. And these are a patient's observations. So you find this in A&E, you find this in the intensive care unit. This patient's actually sick. So heart rate you'd want between 60 and 100, so it's a little bit too fast. Saturations, you'd want sort of 96 plus, that's out of 100, so 96% to 100%, that's obviously quite low. In most patients, you'd want that. End-tidal CO2 is a little bit more complicated, but that basically measures the CO2 that someone's blowing out. Blood pressure, I'll take that actually, it's quite a good blood pressure. So you'd want it, 120/80 is the one that, sort of the area that you want. And yeah, breath rate, so that means their breathing rate is 11 breaths per minute. So my guess, it could be wrong, is that this patient is intubated, has a tube, and someone's breathing for them, but I could be wrong. Good job there's no doctors on the call. Okay, so brief mention to exams, because we are all quite exam minded, us who want to go into medicine. So also disclaimer, this is Manchester, this is not every single medical school, but it gives you a realistic insight into how much we're examined. So we have a progress test. We have a progress test twice a year for 5 years, and it is 125 questions. And at any one time, every year sits it. So that means you sit a progress test in first year, that the same test is used for 5 years. Obviously, the pass mark for the first year is like 20%, and then it goes up to 30%, and then it goes up to 40%, and then it goes up to maybe 60% in the final year. And it literally does what it says on the tin, which is measures your progress throughout medical school. It's not a big deal. If you fail it, you don't even need to retake it. You just kind of, you can't fail more than 2 or 3 in a row, I think, in Manchester. Years 1 and 2, you'll get semester tests. So at the end of each semester, you will get a test. So going back to that cardiorespiratory semester, you get tested on all of that information, essentially. Also multiple choice, also 125 questions from memory. So it's A, B, C, D, E. And yeah. OSCEs, these are called something else now, but essentially OSCEs stood for Objective Structured Clinical Exam, and that's where they get, they're the practical exams. So they get actors in, essentially, and act as patients. You've got the examiner in the corner of the room, and you have 8 minutes to either lead a consultation, to get a history, to examine, to explain something, to explain a drug or a medication that a patient's starting on, to explain some results, to explain some bad news maybe, to go through, you know, do not resuscitate forms about a relative, could be anything and everything, to prescribe something. And a typical set of OSCEs, there'd be 16 stations, and in clinical years we get OSCEs twice a year. Prescribing exams, so that's a 5th year thing, that's a final year thing, so that will be coming up for me in order to, so that I can prescribe next year. SJT, that's also coming up for me. I've got that in December. That's just a final year thing, and it helps you essentially get a ranking in order to apply for a job next year. Manchester do PEP, which is Personal Excellence Pathways, which means that it's projects, sort of research projects and things every year. So first year is poster, second year is maybe a short paper or a short like essay. You have to do it, but it also opens up door, you know, you can choose what area you want to go into. So if you know that you're interested in certain areas of medicine, gives you flexibility to go and explore that a little bit more. And it gives you a good introduction into research, which is good. PPD, this is a portfolio, and portfolio is the bane of every med student's life, because you've got to reflect a lot and you've got to evidence a lot, and that doesn't stop once you qualify. Doctors, even consultants, still have portfolios. It's just one of those things you have to suck up. So failure is a big worry amongst medical students. I had friends who made themselves ill over their exams, and that is just not necessary and it's not needed. You can resit. And it's not spoken probably widely enough. And I've got a lot of friends who've resat their exams, and I know a lot of doctors who have had to resit years of medical school, and it's fine. You're not a failure. It's one of those things. I think medical students tend to be a very competitive bunch of people, and sometimes that can turn a little bit toxic and can manifest in stress and burnout. So if you fail, you can reset. This is just a list of all of the placements that I've had across my 3 years at Manchester. There are a lot more specialties than this, but I think it's mad that I've sort of had an insight into all of these different areas of medicine. So a lot of these words will probably look foreign to people, but ophthalmology is eyes, rheumatology is kind of autoimmune conditions, orthopedics is bones, Jerry's is old people, psychiatry is mental health, endo's hormones, general surgery, it's easy, accident emergency, it's easy, respiratory is lungs, and gastro is anywhere that food goes, essentially, so mouth to kind of colon. ENTs is in ears, nose and throat, neurology is nerves, oncology is cancer, Breast is mainly breast cancer, actually, but some other conditions as well. ID, that's what it says on the tin. So lots of HIV and hepatitis up in Manchester. Paediatrics is children. Obs and gynae, obstetrics, which is giving birth and lovely cute babies, and gynecology, which is women's health, so women's reproductive health. GP, general practice, and then dermatology is skin. So it's wild. Like, you get into medicine and then you just like go through all of these different placements, and you get your eyes opened to so many different areas of the human body that you didn't realise had an area of medicine attached to it. So it's cool. So very quickly, I'll do 2-minute spiel about emergency medicine and why it's the best and why you should all be emergency medicine doctors. So I intercalated last year. I've just graduated, and I intercalated at, it was under the University of Plymouth, but I lived up in Manchester still, and I had a year-long placement in Preston. Lovely, lovely Preston. It's not actually a lovely place, but it's a great hospital. Sorry if anyone's from Preston. I only saw the hospital, so. Yeah, so emergency pre-hospital medicine. This is me essentially helping out. I volunteer to help train police services, army services, and fire services in terms of their medical care and their medical training. So I'm being a simulated patient here. I'm not actually as sick as I look, and they've evacuated me from a cave there. So they run simulations. They have to keep their training up to scratch, and it's something that I really enjoy. West Mercia Police Force we're working with at the moment to train their officers to become essentially able to give quite enhanced first aid care and medical care. So they'd carry oxygen, carry airways, things like that. And that's because around about 70% of road traffic accidents in the West Mercia region are first attended by police officers, not by ambulances. So by providing this training, we can hopefully have quite a big impact on mortality. And there's a study that I'm involved in at the moment that's looking at mortality rates and kind of medical training of their officers, which is really cool, and it's an application of medicine that's not to do with hospitals or med school or anything like that. So this is what I mean by different doors opening. And I recently went on a course by Devon Air Ambulance as part of my pre-hospital course, and that is me, can't really see it down there actually, but surgically intubating someone, which is quite cool. Not someone, sorry, a sheep's larynx. So this is a trigger warning. If you are squeamish, close your eyes, turn around the computer. I will tell you when it's finished. I used to be really squeamish, so I would have appreciated this if I was on this talk. These are all actors. These are not real life situations, guys. So this is all part of the Devon Air Ambulance course that I attended. So very good acting going on there. This was absolutely wild. So this actor was an amputee, and essentially allowed us and enabled us to build a prosthetic on his amputated leg to mimic it having a blast shock essentially, and there was a blood bag down there that was pressurized, and if we didn't tourniquet it tight enough then it would keep spurting out blood. So the stuff that you do in emergency medicine is absolutely wild. This is all simulated and friendly and lovely and not as scary as it would be in real life. This is another one where this guy had a sheep larynx, which is this part of the throat, prosthetically molded onto his neck with a sheet of Kevlar underneath, just to make sure that we didn't go too far. And we were actually able to surgically intubate him, which is wild. Like, it was such a good weekend, and it's yeah, emergency medicine's great. Just do it. Oh god, here's me half one again. I'll flick through this. Specialist generalist is interesting. So basically you don't lose any skills. You don't, go through all of medical school, go through F1 and F2, and then decide to specialize on hand surgery and lose your ability to treat the rest of the body, which is something that I would personally hate. Life-saving stuff. It is life-saving stuff, and it's cool when you see a life being saved, especially if you had something to do with it as well. There's a big focus on teamwork, so you are never more reliant on your nurses, basically, who just are amazing in A&E, as well as just everyone else. It's a massively flat hierarchy in A&E. It's fantastic. Everyone gets on with everyone because they have to. Again, this privilege thing that I was going on about before, that is not, it's never so apparent as in A&E, when people are really having the worst days of their lives, and you're able to be a part of that and help them. Applying your knowledge to suit the situation. So no situation's the same essentially, and you apply all of every little bit that you know. And it's dynamic, it's fast paced, it's fun, you don't know what's coming through the door, it's high adrenaline stuff. It's sad. I think in med school you confront death quite quickly. I haven't actually spoken about anatomy sessions. So in Manchester, in preclinical years, you have a dissecting room, and Manchester use whole body cadavers, which is literally whole dead bodies, to do dissection on. And throughout the semester, you and a group of 10 of you will be given a body, essentially. And these are people who have amazingly and generously donated their bodies once they die to medical research, medical science, medical education, essentially. And there is nothing so powerful and so sort of memorable as learning anatomy on an actual human body. But that being said, it's also a really weird place. Like, these people have been alive and now they're not alive, and people react to that differently. But I'd overall say it's a really positive thing, and I wouldn't be worried or anxious about it at all. It's an interesting thing is the way I'd approach it. Massive respect is given to the bodies, to the family members, who we actually meet the family members of these people who have died. And it's just a very, you can't mimic it in any other way, basically. So that's back to my why do medicine thing. And now we're on to some of the challenges that I said I was going to warn you about. And actually you might get asked about in interviews. It's not all butterflies and roses. This bottom left, this isn't right. And I wanted to put that there because it's a common misconception. So no personal life, no problems. That's just not true. There are both problems and there are both personal lives. So no, ignore that. Like I say, it's 100% worth it. So a lot of people, these are quotes from a lot of people who, when I say I do medicine, either it's family members or it's friends or it's people I've met, I'm met with quite a lot of this. Oh, I couldn't do that. Oh, I wouldn't want to work in the NHS the way it's going. I'd rather you than me. Oh, it's just a hopeless situation. You get those panickers that are just like, oh, it's too much, I can't think about it. Move abroad. I get that a lot. Just up sticks and run. Every doctor is struggling with their mental health at the moment. So all of these are really pessimistic and really negative ways of looking at medicine, and they are really common ways that you'll get people looking at medicine. And I would hate for any of you guys to be deterred through this because of this, because it's so much more than that. Yes, we are in a difficult place for the NHS at the moment. Yes, there are difficulties. Yes, there are challenges, but it's just not a reason not to go into career, in my opinion. Every career has challenges. Every bit of life has challenges. I have faith for the future of the NHS. I don't think it will be in the form that it is now, but realistically, we're all going to have a job. You will always need doctors in whatever format that medicine is delivered in. And I believe in us, Brits. I think we can get through it. So yeah, the aim is to give you a realistic but also optimistic insight into this crazy career. So challenges that we face: stress and burnout, number one, 100%, especially in medical school. Okay, thanks, Holly, but tell me how to avoid this. So balance. I'm not going to read through all of this, but I'm a big believer in just make sure that medicine is not your only life, like your whole thing, the whole thing that you're interested in. Have other things that give you satisfaction as well, including binging Netflix. Long hours at university, that's true. I saw that and I actually really laughed. And sometimes that's true, there's no doubt about it. Like, it's rough, all of your other non-medic mates are on a night out and you've got to prepare for the seminar tomorrow. Hard work is part and parcel of it, and it's up to you to choose a medical school that you think suits your learning needs. Some medical schools are more intense than others, and speak to medical students, speak to alumni. Manchester is kind of renowned for giving you a nice introduction to medicine in first and second year, so it gets you, really sort of allows you to have that sort of balanced life. Third year it steps up a bit. Fourth year is difficult. I was burnt out in fourth year, and fifth year has so far, touch wood, been quite nice again. So it comes with the territory. It's never going to be perfect, but yeah, there are long hours. Homesickness. I had homesickness, 100%. I live about 5 hours away from home, and that just goes for uni in general, I'm afraid, guys. make sure you have ways of getting home. Medicine has really good Christmas, Easter, or Medicine at Manchester has really good Christmas, Easter, summer holidays. You spend a lot of time at home then. And, you know, I think the way that technology is advancing, FaceTime, Zoom, things like that, will really help as well. And get your family up there as well. Challenging environments. So I've touched on this. Distressing scenes, absolutely. Dealing with distraught families, people dying. It's part of the job. It is a necessary part of the job, and it is our duty to be good at dealing with those situations for family members. It will stick with you, and it's not unnatural for it to stick with you. They say around about 6 weeks if you see something really challenging, and it is a stress thing. Like, you're stressed and you're shocked by what you see sometimes. There is support if you ask for it. There will always be support if you ask for it. And having a supportive family and friends will help. Talking, so big advocate of counselling I am, therapy, and kind of being kind to yourself. I don't view challenging environments as a challenge anymore. I'm sure, you know, as a doctor rather than a medical student, I will come across situations that will really challenge me, but I view it as a part of the job, and I'm not scared of it anymore. But I've seen, I think my year in A&E sent me a lot of challenging environments, definitely. Squeamishness. So I used to faint at the sight of a needle. I was dreadful. In my first work experience at Bridport, I saw someone getting their blood taken and I passed out. I was literally then became the patient. I had to get put on a bed and my legs up in the air, and I thought, how on earth am I going to become a doctor? So what I would hate is for any of you to be squeamish like I was and think, well, I can't be a doctor, because that is not true. Essentially what I've done is I've desensitized myself to it. And now, I mean, I spent a year in A&E, like, now I'm absolutely fine. And it is possible. I was as squeamish as you got without really being phobic. I wasn't phobic, but I was a fainter. And it wasn't even that I was scared of it. Like, I didn't throw up or anything. It was literally my body's physical reaction to seeing blood was just to faint. Which is terrible, but hard work, you get through it. And so that's a shout out to all of my other squeamish medics out there. Mental health struggles and financial struggles. So I'm coming to the end of my talk now, guys. I asked my brother, actually, what would be my brother's 15 and hasn't decided on medicine, but I sort of said, what would be the main deterrent of you wanting to be a doctor out of interest? And I think there's a lot in the press about mental health struggles and financial struggles of med school, essentially. There we go. Here's some, just like, I don't know. It's important to get it out there. It absolutely is important to get it out there and to tackle challenges, things like that. But this is something I feel really strongly about. There are definitely financial difficulties as well. But it's getting there. It's not perfect, but it's getting there. Okay. And it's getting there in these formats. So the BMA is a fantastic sort of resource where that's the British Medical Association, and they offer free counselling, free peer support services, whether or not you're a member. This is Manchester, and we're starting to see some more of this now. So student pastoral support is what it says on the tin. So it's sort of directs you to mental health and wellbeing sort of avenues. There's a section on wellbeing, and then there is actually also a section on quality, diversity and inclusion, which we love to see. There is still discrimination in medicine, guys. I think there's still a lot of discrimination in life, isn't there? But it's something that I feel very strongly about. There is effort now to tackle it, and my hope is by the time that you guys are where I am, we will be far further down the road. The funding thing is also an issue. So the last year, so fifth year, essentially fifth and sixth year are difficult financially, and I would be doing a disservice if I didn't warn you guys about this. It's not a reason not to do it, and it's not a reason to like back away now running and screaming. There are ways around it. Having a job is possible in medical school. It's probably not advisable around exam times, and it's probably not advisable coming up to finals, which is where I'm going up to, but it is possible. And it is essentially really discriminatory, because you get students who can't afford to live, and you get students who don't have that the sort of parental, say, financial support. But that will hopefully, we've got a massive campaign going on about this at the moment. It's something that I'm quite heavily involved in. It's something that my friend is also very heavily involved in, and we are slowly but surely getting somewhere with it. So my advice is, know it's a challenge, be ready to talk about it in interviews, going back to boring interviews. Know it's challenging for yourself, but know that there is stuff that we are doing to tackle it, and hopefully by the time that you are where I am, it shouldn't be as bad as it is now. Okay, so in summary, I'm so sorry that took so long, but hopefully it's been useful. Medicine is like one of the most bizarre things. It really is, and I stop and think about it quite frequently. I just think, what the hell have I just seen? But it's brilliant. It's fantastic. It's like one of the best career options you could ever go into. And yeah, I think we're going to go on to the Q&A now. I have seen the chat, or I've seen something pop up quite a lot. So if I just stop sharing my screen and then get onto some questions, which I think would be really useful for you guys as well. Lucy, I don't know if you are still with us. I'm not sure if you are actually. So
yeah.
Oh yeah, you are.
I am. Hello. Thank you so much. That talk was really, really incredible. It was so comprehensive and covered so many different things. I will just stop recording now, actually. But no, that was so fantastic.